Welcome to the 47th Lester Breslow Distinguished Lecture. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. We've come together today to honor and celebrate the legacy of Dr. Lester Breslow, who was known to many as Mr. Public Health. He was an extraordinary public health leader, a widely renowned researcher, professor, and mentor, and the second dean of our School of Public Health. Throughout Dr. Breslow's career, which spanned more than 70 years, he had tremendous impact. He provided an evidence-based case for the critical importance of prevention. His groundbreaking findings linked healthy habits with living a longer life, like exercising regularly, getting enough sleep, eating well, and abstaining from smoking. His work also provided the key data linking smoking and lung cancer, arguably one of the greatest achievements of public health to date. Dr. Breslow held many important positions throughout his extraordinary career, including his role as president of the American Public Health Association and as director of the California Public Health Department. And in 1972, Dr. Breslow served our school as dean, a position he held until 1980. I'm so pleased that Deborah Breslow could be with us today. Deborah was very much a partner in Lester's career, including his leadership here at the UCLA Fielding School. We are all incredibly grateful to Deborah for her dedication and commitment to our school and to public health. Thank you, Deborah. Dr. Breslow played an important role in mentoring the next generation of public health leaders, which is also a characteristic shared with the 47th Lester Breslow Distinguished Lecturer, Dr. Roger Detels. Dr. Detels is a distinguished research professor of epidemiology here at UCLA Fielding School of Public Health, and also of infectious diseases at the Geffen School of Medicine. During his more than 50 years as a faculty member here at UCLA, Dr. Detels has served as dean of our school immediately following Dr. Breslow's tenure in that role, and as chair of the Department of Epidemiology. In 1981, he began a study of AIDS here in Los Angeles. And 2 years later, he became the principal investigator for the multi-center study of the multi-center AIDS cohort study, or the MACS. The MACS study is one of the largest cohort studies of HIV/AIDS in the world. And in fact, I first met Roger very early in my career when the MACS study was first being started. My long collegial relationship and friendship with Roger spans nearly 40 years. MACS contributed some of the earliest evidence about the route of infection for HIV transmission. And Dr. Detels published a landmark study showing that some men were resistant to HIV infection. In 1988, in an effort to build leadership capacity overseas to fight HIV/AIDS, Dr. Detels began the UCLA Fogarty AIDS International Training and Research Program. To date, more than 100 renowned public health leaders in China and Southeast Asia are graduates of the Fogarty program, having received a master's or a doctoral degree, and many more have benefited from training as postdoctoral scholars. Dr. Detels has held numerous leadership positions in the field of epidemiology over the years and received numerous honors, including awards from the governments of China, Thailand, Cambodia, and Vietnam. Now, Dr. Detels' lecture today will be followed by a question and answer session, and we ask that you submit your questions by clicking on the Q&A button near the bottom of your screen. You will deliver the lecture recognizing opportunities. Please join me in welcoming Dr. Roger Detels.
Good afternoon. I would like to thank the organizers of the Breslow Distinguished Lecture series for the opportunity to present to you. I picked the title Recognizing Opportunities because I think that's a key component. Of course, one can think of recognizing opportunities with different applications. So I will discuss opportunities to elucidate disease pathogenesis, to inform public health policy, and to develop and implement evidence-based interventions. And finally, to contribute to posterity, primarily through training. Before I begin the formal presentation, I'd like to acknowledge three individuals who have shaped my career. I did my residency at the University of Washington with Tom Grayston, who is the founder of the School of Public Health at the University of Washington, and subsequently the Vice Chancellor. It was Tom who taught me how to recognize an opportunity and then to go for it. You've heard about Lester Breslow, Mr. Public Health. He was a role model, he was a mentor, he was a friend, and throughout my career, Lester was an advocate. And finally, I'd like to thank Professor John Fahey, who's professor of immunology, who provided the initial $3,000 to start the cohort studies of men who have sex with men here in Los Angeles, and subsequently became the multi-center AIDS cohort study. Dr. Fahey provided immunologic guidance and assured that I would have colleagues who were pioneers in the field of immunology. It's often said that people are an infectious disease epidemiologist or a cardiovascular disease epidemiologist or a neuroepidemiologist. But I like to stress the fact that I am an epidemiologist. I use epidemiology to study a range of problems. And so I've listed a few of those problems that I've used epidemiology for. And you'll notice that I've listed the colleagues who helped me in each of these areas. And to them, I owe a tremendous debt of gratitude. So I started off in trachoma. Shortly thereafter, evaluated the rubella vaccine, air pollution, which I'll talk about in a minute, multiple sclerosis, which I'll talk about in a minute. And the last 40 years, I have concentrated on HIV/AIDS. And again, I've had wonderful colleagues in these studies that we've done together in HIV/AIDS, and I will discuss a number of them later on. And then finally, I've also done studies on sexually transmitted infections, primarily internationally. So now I'd like to give you 4 examples of opportunities realized. The first one was an opportunity that occurred to me shortly after I arrived at UCLA in 1971. I was looking out the window trying to think, what am I going to do research on? Because I realized that in order to survive at UCLA, one needed to do research. And as I peered out the window, God revealed it to me, air pollution. So I followed that up by looking to see what kind of monitoring was going on in Los Angeles, and was delighted to find out there was an extensive network of monitoring stations throughout Los Angeles County. I also learned that the Tuberculosis Association had a mobile lung function laboratory, which I could use for the studies. And finally, I enlisted the help of 2 great respiratory physiologists, Stan Rokow and Donald Tashman. We decided to concentrate on 3 study areas with different levels of pollutant. For the area with primary pollutants, we picked the Bixby Knoll, which is in Long Beach, which is directly downwind from the oil refineries. For the area exposed to photochemical pollutants, we picked Glendora, which is in the East San Gabriel Valley. And for the area with low levels of pollutants, we selected Lancaster, which at that time had very low levels of pollutants. What we did was we did repeat testing of lung function in the same individuals in these 3 communities over 5 years of time. And what we found was there was a lower growth or retardation of lung function in children in both of the polluted areas, and that there was low lung function over time in the adults in both of the polluted areas. This study provided evidence for public health policy to set higher air quality standards. Then I'd like to tell you about another study, which is in some respects amusing. As part of my teaching, I would give a lecture on the multi-center age cohort study. And because I wanted students to learn about all aspects of research, I would spend a few minutes presenting an overview. My program director would then talk about what are the issues and problems in implementing these ideas and concepts into a reality study. And finally, I would have a participant who would present their view and their perspective of being a participant in the study. Oh, I got ahead of myself. Oh, excuse me 1 minute. Yeah. The one participant, when asked what was the most difficult part of being in the study, said that, well, they asked me questions about what I did, who I did it with, how many times I did it, and all these details. And the interviewer looked like my grandmother. On another occasion, the participant responded by talking about his idea of optimal treatment. This was before treatment became available in the early 90s. And he said that he had been taking bitter melon every day from 1985, and he had actually doubled his T cells from 2 to 4 per cc. 2 to 4? How do you survive with 2 to 4? Normal is 600 to 1,000 per cc. So that gave me the idea to compare men with fewer than 50 CD4 cells who die within 6 months with those who survive for greater than 2 years. I was fortunate that Janice Georgie, a brilliant young investigator who died far too early, had pioneered studies of cell activation, primarily the CD38 marker on cells. What we found was that there was high persisting levels of cell activation, CD38 marker on cells in those individuals who went on to die in less than 2 years, whereas those with low levels of CD38 activation marker survived for more than 2 years. So this study underscored the importance of continuing persistent T cell activation in the pathogenesis of HIV. And it is an example of recognizing opportunities to contribute to an understanding of pathogenesis. Then I was also fortunate enough to be invited to participate in a study of the opinion leader intervention by Professor Mary Jane Rothram, a brilliant researcher in the area of interventions. And she was doing a study in public markets in Fujian, China. As part of that study, all the participants in these markets were asked about whether they had multiple partners, whether they had STI symptoms, and all participants were tested for chlamydia and gonorrhea infection. The sexually transmitted infection rate was 19%, but only 5% of the market vendors reported multiple partners and/or symptoms. Clearly, there are a lot of immaculate infections. And then the bottom line was that 80% of the individuals who were infected with either gonorrhea or chlamydia were in fact reporting no symptoms. This indicated the need to modify our interventions. It was clear that all sexually active individuals should be tested for STIs, and that symptom-based programs will miss most people who are infected with HIV. Finally, I'd like to talk about multiple sclerosis. As I mentioned before, I started my career off at the National Institutes of Neurologic Disease and Stroke. About the time that I came to UCLA, President Nixon had a relative with multiple sclerosis. Thus, multiple sclerosis became a funding priority and there was money available. So I decided that I had an opportunity to study multiple sclerosis because I had done my residency in a high-risk area for multiple sclerosis, Seattle, Washington. And I was living in a low-risk area for multiple sclerosis, Los Angeles. In the process of doing that study, we identified families that have more than one affected member who has multiple sclerosis. So I realized that there might be a genetic component. So I enlisted the assistance of Paul Terasaki, whom many of you may know, who was a pioneer in the area of tissue typing in the world. And I asked Professor Terasaki if he would perform haplotype testing. What we found, as expected, was all the affected members of the family had the same haplotype. But unexpectedly, some of the uninfected siblings shared that same haplotype. So this study contributed to our understanding of the pathogenesis of multiple sclerosis because I hypothesized that there was a genetic susceptibility to multiple sclerosis in some individuals, and that a second factor acted on those who had that susceptibility gene. Within the last 3 to 4 weeks, there have been studies reported which have implicated Epstein-Barr virus as also being involved in the pathogenesis of HIV. Excuse me, the pathogenesis of multiple sclerosis. This presents another opportunity, which unfortunately I'm too old to pursue. So the opportunity is to look at whether EBV patients who have multiple sclerosis have a similar genetic profile which differs from EBV patients who do not have MS. That is to say that the patients who have MS have a combination of both EB infection and genetic susceptibility. Now, Dean Brookmeyer suggested to me that I should present some of my ideas and tips for younger investigators and to what they should pay attention to. First, I think it would be helpful to identify and learn from a productive mentor. 5 minutes spent with a productive mentor is worth more than 5 hours spent with a non-productive mentor. And I certainly had that with Tom Grayston. Set aside creative time. There's going to be a huge amount of pressure put on you to do many different things, serve on committees, do bureaucracy, etc. Set aside creative time with no interruptions. Consider what has been done in the areas that you're interested in, what needs to be done, and what you can add. Know what your strengths are, and also know what your weaknesses are. Recruit weak colleagues who have the expertise that you lack. Very important is to establish a positive, creative, and enjoyable environment for staff, participants, and colleagues, so they will get up in the morning with an enthusiasm for working on the research that you're directing. Very important, respect your staff. They can either make you or they can break you. Hire someone to handle the ever-expanding bureaucracy. You've been hired to have and implement great ideas and concepts, not to crunch numbers and to handle bureaucracy. Share first authorships and presentations with your colleagues. That's part of maintaining their interest and their enthusiasm. You're going to have low points and you're going to have high points in your career. How you go on, how you recover from career low points, not successes, is what defines your character and your future. And finally, particularly relevant throughout your career, never stop learning. And I hope that's true for me. Now, the final recognition of an opportunity that I wanted you to know about was, of course, posterity, and that's, of course, teaching. And as part of this presentation, I've had the opportunity to follow up and see what some of my former students are doing. And I've listed a number of them for you. It has always been my wish to have students who would do better in their careers than I have done. And by that metric, I have indeed been unusually successful. A few examples, I won't discuss all of them in the interest of time, but for example, Zhenyo Wu, who is not only a close colleague and friend, but who became the director of the very successful HIV/AIDS control program in China, who is the chief epidemiologist for the China Centers for Disease Control, and who has been a leader in the successful fight against SARS-CoV-2 in China. Two of my former students have become ministers of health. Catalin Rappi, who was the Minister of Health for Hungary, and Xingzhi Tu, who was the Minister of Health for Taiwan. And Soumya Swaminathan, who was the Director General for the Indian Council for Medical Research, and who is now the Chief Scientist for the World Health Organization. I also would like to mention Swaroop Kaur, who is the Director of Communicable Diseases for WHO Zero, and who himself has received WHO award for his contributions to world health. Professor Phanthanak Sapon, who is almost like a son, became the Chancellor of the Cambodian University for the Health Sciences. Paolo Teixeira became the Director of the HIV/AIDS program for WHO. And at one point, almost all of the directors of AIDS programs for Southeast Asia and China were UCLA graduates. Dr. Kantanu Vieng presented a challenge in how to pronounce his name, but he also became the director of the Lao Sexually Transmitted Disease programs. I'd like to also mention many of my colleagues in Thailand who have become very successful. I will mention in particular Panati Thamowijaya, the director of the AIDS Research and Innovation for the Department of Disease Control for the Thai Ministry of Health. Finally, I'd like to also mention Ken Kaiser, who is one of my American students, who became director of the Department of Health and Human Services for California, and subsequently became Undersecretary for Health of Veterans Administration. And one of my very dear friends, as well as my former student, Hannah, who is the innovative Dean of the School of Public Health, one of the top schools of public health in China. And finally, I would like to thank a number of people. I'd like to thank, first of all, and most of all, my wife, who has been supportive through all the lows as well as all the highs, and who provided me with great sons and grandkids who have taught me humility, and a fabulous staff who've helped me in every aspect of my career. And as you've seen from the previous slides, I've had the good fortune to have outstanding students. I'd like to give particular thanks to the courageous men of the multi-center AIDS cohort study. We living in 2022 cannot really appreciate how much courage it took to participate in the MACs in the early days when the atmosphere towards men who have sex with men and through HIV AIDS was unbelievably toxic. And of course, I'd like to thank all the willing participants in the many US and international studies and the brilliant collaborators from many countries who are dedicated to improving public health in their respective countries. And finally, I'd like to thank UCLA for providing a creative, supportive environment and wonderful collaborators with whom to create these studies. And then you'll forgive me, but I will end with a sales pitch. We have just published the 7th edition of the Oxford Textbook of Global Public Health with colleagues from India, Australia, China, and England. And that has been a wonderful experience. So at this point, thank you all for your attention, and I'll be glad to answer questions.
Roger, thank you. That was terrific. It was inspiring, and we're so pleased to have you with us today. While we're waiting for questions to come in, and please use the Q&A button, I'd like to start off with what's on everyone's mind, which is the COVID pandemic. And I was wondering, what you think where we're going to be in 6 months and beyond.
Well, thank you, Ron, for a tough question. I've been thinking about this for some time, and I think we are currently actually suffering from 2 epidemics. The first epidemic, of course, is the COVID epidemic, which we all are very much aware of. The second epidemic is vaccine deniers, and it is the second epidemic that is in many respects the more serious epidemic, because the epidemic in the future is going to be driven by individuals who refuse to be vaccinated, and they are going to determine, in point of fact, where we are going. I think we are fortunate in that we do have vaccines that are good, and we have amazingly creative individuals who are creating very good vaccines. So,
Roger, with regard to the anti-vax and the issue of how we communicate public health and build trust in what we do, are there any lessons learned, or can we do better in training and in public health practice?
Another tough question. I think that I often tell my students that public health is politics, because if you look at all of the public health interventions, there is a behavioral component. You can make the best vaccines in the world, but if somebody won't let you vaccinate them, it doesn't matter that you had a good vaccine. So we have to create some way that people understand public health interventions. In the beginning of the AIDS epidemic, we were fortunate to have two very important spokespersons. One was Magic Johnson, who really put HIV/AIDS on the face of actually the world, since he was a world-renowned figure. And the other one was Elizabeth Taylor, who became the champion of fighting HIV/AIDS. I think we need to find spokespersons that have that much stature with the public and who can communicate. We also have to deliver simple, straightforward messages. Unfortunately, COVID is a difficult disease. I'm often asked what I think we should do in the future with COVID. And I think there is only one certainty in terms of COVID, and that is uncertainty. And unfortunately, what that has led to is mixed messages coming from CDC and from the government, because as we discover more things about COVID, we need to change our directives to the public, and that has confused them. Hopefully, as we march forward and we have capable vaccines, and that a high proportion of the population, at least in the developed countries, are vaccinated, we can deliver messages that are more simply understood and better able to be implemented by everybody.
Yeah. Well, Roger, I'm going to ask you another question that's been on my mind is we're hearing a lot in the news recently of relaxing of many mask requirements, of a return to normal. What do you think of that? Do you think it's premature, or do you think it's about time? What's your take on that?
Well, there's a lot of ifs and uncertainties in trying to answer that one. I think as more and more people become immune, either because they've been infected or they become vaccinated, and we realize that the majority of infections, for example, with the Omicron variant, when it does cause disease, is less likely to cause very severe disease and death. So I think it is probably possible for us to pull back a little bit on the rather draconian measures that we've had. The SARS-CoV epidemic has caused tremendous social damage in terms of interpersonal relationships, in terms of feeling of security, et cetera, as well as the terrible impact that it's had on businesses. So we're going to have to learn to live with it. But hopefully we can learn to live with it as an endemic disease so that it has a minimal impact, as we have done to a large extent with the influenza epidemic.
Roger, I can tell you there are lots of your former students who are online, live, listening to this. And one of the questions that has come in is, how is your global experience and work in Asia and beyond influenced your approach to research and collaboration?
Well, actually, since the majority of them were PhD students or master's students and had to do dissertations, I've done, literally close to 75 to 100 different research studies overseas. And as each of the students brings a certain different approach, and they also bring an understanding of their culture. And so they've taught me, but it's a little bit like raising, I tell my students, it's a little bit like raising teenage sons. You gotta have big ears and a small mouth. Listen, because if you want to have effective public health intervention, you got to listen to what they're telling you and act accordingly. So thank you, students, for helping me to have big ears and a small mouth.
Question came in about the MAX study, which has been going on for decades. What is the MAX study focusing on now, and where do you see it headed in the next few years?
I think what we've discovered now, the MAX study has now been over 40 years. We've been funded to go through early 2027. There's been a realization that we have this huge cohort. So we have specimens and we have data dating back more than 40 years. So we can begin to look at things like, what are the precursors, for example, of cardiovascular disease? What are the precursors of many of the neurologic diseases or the cognitive diseases that occur with age? Because we can go back 5, 10, 15, 30 years, and we can see what their immune profile was. We can see what their immune structure was. We can look at their habits that were developed over those years. So we can begin to find out what are the predictors of many of these outcomes. And I'm, in thinking about this, I'm reminded of a very famous saying by the Dodgers catcher, Yogi Berra, who said, it's very hard to predict, particularly in the future. And so where we're looking now is we're looking at not just HIV and what diseases are more common with HIV. We've got controls. These are men who do not have HIV, and we have over 40 years of history on them. And I think they're going to provide very interesting information about these precursors of a whole host of diseases other than HIV/AIDS, and which will provide evidence for implementing new interventions and catching disease before it becomes severe.
Great. A number of questions coming in about careers and perspectives. And one question is, Roger, is there something you wish you knew 15, 20 or more years ago when you were at a different stage in your career and looking back now?
That's really a tough one. I look back and I had wonderful mentors and my colleagues and my staff. I really owe a tremendous amount to them. And I look back and, there's been some low points, but they weren't necessarily my doing. They were low points in terms of what was happening in terms of public health per se and in terms of epidemiology. I don't think they would have been avoidable. So I think what you learn to do is you learn to recover. So you do something that is, well, the resistance to infection. When I first came up with that some men are resistant to infection, I was censored by the New York Times and by many people in the scientific community because the implications initially were very serious, I hung in. And I think that experience and other experiences taught me when to hang in and when to listen, which is a very hard thing to do.
I know, Roger, I had the opportunity to work with you a lot and get to know you well. And I do know you speak your mind, and I certainly appreciate that. And then how do you deal with that when you get criticism, when you get in a professional career, when you hit those low points? How do you bounce back? How do you sort of take it and move on?
Well, I have another saying. I have lots of sayings as you get old, but I like to say that about advice. If you take the advice, following it is optional. If you don't get the advice, taking it is not optional. So how I try to handle it is I get the criticism, my gut reaction, of course, is, oh, that's terrible. He's crazy. He doesn't know what I'm doing. And then I calm down after a day or two. And I try to say, okay, there's a problem here. Should I be doing what he or she are telling me to do? Or should I begin to realize that I've not really communicated what I'm doing adequately? And so I try to reflect on which of those is the culprit and try to act accordingly.
Roger, there's a question from the audience asking about health indicators and how we can measure in California or beyond what we should be measuring. Are there a couple of indicators, health indicators, that you think are especially important to improve population health?
Well, I think actually I would go back to Lester Breslow's pioneering studies. His studies really underscored the importance of behavior. And he came up with the health habits that prolong life and improve the quality of life. So I personally think, for example, that exercise is very important, that one should continue to exercise. We had a professor of nutrition at UCLA, Roz Alphenslater, and Roz's motto was all things in moderation. And I think that's another thing. I mean, alcohol in moderation, steak in moderation, et cetera, are good rules to live by. I think in particular, maintaining a social support network. This has been one of the real culprits of the COVID epidemic, is that I think it's important to have a social support system of friends who are supportive, whom you enjoy being with, and you can explore life with. And so those would be a couple of my suggestions.
Yeah, and I know I would see you at the Wooden Center at lunchtime and knew that how important exercise has been to you. So you live what you say, and you do what you say. So there's a question here from a first-year MPH student in epidemiology, asking, do you have any, what do you see as the future opportunities for work in the field of infectious diseases?
Oh, I think there's a wide open field. I often show my students the quote from the Surgeon General. I'm blanking on his name, but it was in the late 1950s or the early 60s, who announced to Congress that we had overcome infectious diseases and we should now concentrate only on chronic diseases like cardiovascular disease. And then, of course, along came HIV/AIDS, and along comes SARS-CoV, Ebola, et cetera. I think we can trust the future to present us with a whole range of new diseases that we're going to have to learn all about. And they're going to be like SARS-CoV-2 in that they're going to present challenges. I think one of the challenges, the major challenges for SARS-CoV-2 is that we have a whole list of things that we've learned from other infectious diseases, principles of infectious disease, spread, et cetera. And we tried to apply them to SARS-CoV-2. It didn't work. SARS-CoV-2 is different. And we're going to hit new infectious diseases and emerging diseases, and we're going to have to learn all over again. So that's a real challenge. So if you're in the MPH or in the PhD program, you got a wide open field ahead of you. There's going to be lots of opportunities. It's going to be a real challenge for you.
You know, Roger, sometimes as all researchers, we start a project and it doesn't go anywhere, failure, or we get stuck, or it doesn't end up having a lot of impact. How do you, when we think about opportunities and things coming along, how do you look ahead and see which ones are going to be the ones that are most impactful or the ones that'll be most fertile to pursue?
Well, that's a toughie. I'd like to say male intuition, of course, but one of the reasons that I've jumped around a little bit in different fields is because I make a contribution to a certain field and I feel I've gone as far as I can go with my expertise. An example of that is the multiple sclerosis studies. We had a number of opportunities from the laboratory and from the molecular perspective to design studies which could elucidate more of the molecular factors and the pathogenesis factors. But we reached a point where we needed new leaps forward in the area of basic sciences. And so I realized that until those arrived, I didn't have the expertise to go forward. And so I actually realized that what I really wanted to see was what goes on in terms of immunology, particularly during early life. And it was that turned me on to HIV/AIDS, because here was a disease that was primarily an immunologic phenomenon, and studying it was going to help me elucidate the function of the immune system as it has.
Great. Question from the audience. Distrust of science in general is a huge public health problem. Some people will never understand, but is there an opportunity here? Can epidemiologists and public health practitioners help people understand better how science works?
Well, I think there's been a whole new field that's been developed recently, and NIH is funding. It's called implementation sciences. The problem with many of us who are researchers is that we're sort of pie in the sky academics. We come up with an observation, and it may be an observation on pathogenesis, for example, and we don't go that extra mile, which to say, okay, so that's very interesting, but why is it relevant? Why is it relevant to me as an American or as a Cambodian? What does that tell me that I should be doing, or where we should be going in terms of developing evidence-based interventions, et cetera? So we've got to learn to step back from the scientific verbiage and to translate what we've done into interventions that the public can understand.
Great, thank you. A question from the audience about the anti-vax issue and how we can increase vaccine coverage. What do you think are the most pressing research questions that we should be working on to get universal uptake of vaccines?
Well, I think there's a number of areas. One is, as I commented earlier, you got to get the vaccine into them if it's going to do any good. So there's a whole range of behavioral kinds of research projects that can be done. What's the difference between the vaxxers and the anti-vaxxers? Why are they anti-vaxxers? A lot of it is unfortunately politics. Politics has been one of the really bad guys in COVID-19 epidemic. How do we deal with politics? How do you counter politics? These are behavioral issues. So that's one area. The other area is molecular. We have a vaccine that's pretty good for covering all of the different variants that we've seen of SARS-CoV-2 to date. That doesn't mean they're going to be effective in the future. We need to get a generic vaccine that's going to cover all of the evolving variants of SARS-CoV-2. We have the same problem in HIV. We don't have a vaccine that covers all the different variants of the HIV organism, for which there are millions of different variants. And it's the problem with influenza because we don't have a vaccine that covers all of the different types of influenza. So there's an area in the behavioral area, and there's an area in the molecular and basic science area that I think is important.
Roger, using your crystal ball, do you see we're going to be in a situation like we are with influenza, with yearly vaccines as strains and variants change?
Yeah, I think until we develop a vaccine that covers all the different variants equally effective, that we're going to be in a situation like we are the influenza. And that's not too terribly bad. We can, it's not a big burden to get a new shot every year. We'd of course preferred that it was like measles and for life, but getting a shot every year to protect yourself against SARS-CoV-2 is a small price to pay for leading a somewhat normal existence and social interactions, et cetera.
The question from the audience about technology and digital health and some of the new tools that we have. Do you see a role? What's the role for it in public health and epidemiology going forward?
I'd have to demur on that one because I'm not so familiar with the new area of digital science. I do think one area in epidemiology that's increasing, and Ron, you certainly know about it because you're one of the pioneers, and that's in modeling. And a lot of the work that you've done and that other people have done in terms of modeling has been very helpful for anticipating where the epidemic may go and what's going to be the impact of different interventions, because you can model the impact of different interventions on the future of an epidemic or of a disease. So that would be my response in the area of
yeah, you know, with models, I'll just say that some, particularly early on, a number of the models with COVID actually were incorrect. So, you know, we have to be knowledgeable consumers of models and their results and the assumptions on which they rely.
I'm tempted to ask you, how do we do that, Ron?
Well, well, I think we're getting short on time, so I'll do more on that one. But there was a question from a member of the audience about looking at opportunities in one's career at different stages of your career, whether you're an assistant or an associate or a mature full professor investigator. And how you think about your career at different stages and the kinds of opportunities to pursue.
Well, I think that different stages of your career present different opportunities. I think early on in your career, you really are learning all the latest methodologies and all the latest strategies and all the different things that you can do with computers and mobile phones. So early in your career, you tend to pick up these technical expertises. As you age in your career, you begin to have more understanding in terms of the ability to conceptualize a problem. I think one of my strengths has been my ability to conceptualize a problem and then to conceptualize an intervention. And that, I think, comes with experience and realizing opportunities to do research. Once I've done a research project and I finished it, I'm not interested in it anymore. My only interest in it is what does it tell me about what's next? And that's what I'm looking for when I finish a study.
So if you were, I'll take off on that. If you were looking at what's next, and you were, a young researcher at this point who's looking for different areas to go into, where would you start putting energies into, and where would you like to be working in? What area or aspect of public health?
Well, that's a tough thing. I've enjoyed all the areas that I've worked in, and I'm still throwing out ideas to some of my colleagues. I recently see an opportunity, for example, in the Max to look at the issue of air pollution and effect on African American women in particular, because of the nature of the Max study now that it's expanded to include women. There's still lots to be done in the neurologic diseases. We have Alzheimer's disease. All of us as we age, and you will do it too, Ron, start worrying about forgetting things and the worry about the onset of Alzheimer's. Are we really there already? There's a whole host of things to be done in the areas of Alzheimer's. As I commented earlier, there's a whole wide open field of infectious diseases. I can't tell you what the next emerging disease is, but I can tell you it's going to be there. So I think it really depends on what you find to be interesting, because just about every field has some unanswered questions. And the nice thing about epidemiology, as I commented earlier, is it's a methodology. You can apply it to any host or any range of disease problems. And that's the fun of it, is how do you do that?
Well, one thing, and you've done it so successfully in your career, which is to be nimble. And as the public health problems change and as they present, you move to those that are really pressing and are on the top of our agenda, and you sometimes have to move, and you have to have that be prepared to make those moves. And in fact, there is a question here from an audience member about how do you prepare for a successful career in public health and epidemiology? What should students do? What should they be learning? How do you get the preparation that you need?
Wow, that's a tough field. I mean, I'm a professor, so I have a bias, and I think you need to study. I think one of the we have courses on methodology, and they become ever more sophisticated and ever more technical. But and I think they're very important, and they're the basis for a long career. But I think of the courses that I've taught, and I've had a number of my students who have said that, is read the literature, critique the literature. I taught a course in which it was what was often called a journal club. You read the article and you think, okay, what did they do right? What did they do wrong? What are the implications of what they've done? And where do we go from here on the basis of this paper? And if you do that kind of exercise, you're going to hone your skills.
Well, that's great advice. And And you know, this hour has gone really fast, and we've come to the end of it. And you've given some great examples of opportunities, and you've had a spectacular career, which continues. And I know I have learned a lot from this hour conversation together. And I want to really thank you for being with us today, for delivering a wonderful lecture. I want to thank all of you for joining us today and also helping us carry on the extraordinary legacy of Dr. Lester Breslow. Have a wonderful afternoon, everyone. Thank you again, Roger. Thank you, everyone, for being here, and take care.
Thank you all.